How to insert an endotracheal tube, allegedly, with diagrams, black and white edition. Make sure the patient is being ventilated by bag mask as you prepare.
Indications for endotracheal tube intubation include inability to maintain patent airway, failure to ventilate, failure to oxygenate, inability to protect against aspiration, and anticipation of patient fatigue causing respiratory distress. Contraindications include trauma to the larynx or airway obstruction. Complications include pneumothorax or hypoperfusion of lung caused by advancing the endotracheal tube too far and into the right carina, or by advancing the endotracheal tube into the esophagus.
Repeat attempts of advancing the endotracheal tube without a clear view can cause damage to the vocal cords, larynx, or edematous tissue and bleeding, making intubation more difficult.
Intubate when PaO2 falls below 65 on room air, hypercapnia defined as PaCO2 greater than 45, oxygen saturation falls below 70%, tachypnea defined as greater than 40 breaths per minute, or when patient condition deteriorates. Supplies needed include a laryngoscope, suction, sedative and paralytic drugs, 10 cc syringe, endotracheal tube, stylet, tape or ET tube holder strap, capnography, and a bougie in case of a difficult airway.
Make sure the laryngoscope light works.
Blinded by the light.
Prior to intubation, you should assess the airway for identification of a difficult intubation. Look, evaluate 3, 2 rule, determine Malapati score, look for obstruction, look for obesity, especially in the neck, and evaluate neck mobility.
Elevate head and extend neck into sniffing position. Suction mouth, removing extra secretions. Inflate the cuff on the endotracheal tube to ensure that it is not compromised. Open mouth with thumb and middle finger using scissor technique and carefully insert the laryngoscope. Lift the scope, being careful not to chip teeth. Visualize the vocal cords and advance the endotracheal tube through the cords with stylet inside of the tube. Carefully remove the laryngoscope. Remove the stylet and inflate the cuff. Attach the bag to ventilate. Secure tube with strap after confirmation of placement. To confirm proper placement of the tube, watch for rise in chest. Auscultate the lungs bilaterally to listen for breath sounds. Evaluate capnography on the monitor. In addition, a chest X-ray can be obtained. Tips and tricks. Brake to ventilate if you are struggling. Always remember the airway. Change something if you are unsuccessful. Change the patient's head position, the blade, or yourself. Do not be afraid to ask for help. You can apply cricoid pressure using the Selleck maneuver. This can avoid regurgitation of gastric contents and press the vocal cords down into view. Or you can use a bougie in case of a difficult airway. Insert the bougie through the vocal cords and then slide the ET tube over the bougie. Badness and bougie, holding up here like a doozy. Malapati scores of 4, we got OSA and obesity too. My patient is badness and bougie, holding up here like a doozy. Malapati scores of 4, we got OSA and obesity too.